Good morning, everybody. Muy buenos días a todos. I imagine people will continue to join us, but let's get rolling. Thank you all for those of you who have come in just now. I am your host, Dr. Gabriela Lemus. I am the Executive Director of Maryland Latinos Unidos. And joining me this morning is Andrea McIntyre Hall, the Senior Director, Community Health at Kaiser Permanente, Mid-Atlantic. I am incredibly pleased to have her join us today. A little housekeeping before we get going. Please place your names, organizations, and where you're located in the chat. I always like us to have a sense of where we're from, right? What county are we in, city? Also, if you have questions that occur to you while we're speaking, sometimes it just spontaneous, please put them in the chat and we'll try to get to them during the session. I want to provide a little bit of context for why I'm so excited to have Andrea join us today. Last month, I had the privilege of participating in Kaiser Permanente's conference in Washington, D.C., where the most impressive group of healthcare providers, public health officials, and associations like the American Medical Association and the CDC Foundation came together to discuss the future of public health post-pandemic. I came away more than inspired, actually committed to continue in the vein of work that was discussed there. I came away with a sense that we are in a unique moment in time post-pandemic, but not necessarily post-healthcare crises. Now, I believe, honestly, that many incredible shifts in thinking were made in the last 5-6 years in terms of broadening health equity discussions, diversity, equity, inclusion, and justice, and how it is possible for systems to come together in innovative ways to bridge the really deep challenges all of our communities face in terms of healthcare access. I think for many of us today, especially in the nonprofit space, the concern is that the lessons we learned during the pandemic may already be starting to fade. Already in Maryland, for example, some nonprofit organizations are experiencing a withdrawal of funds from projects like health literacy post-pandemic. And my concern is that it's an indicator of a recalibration of what will we prioritize, with public health and the healthcare systems, not only in the state, but on a national level. I think, again, because I'm an observer, right? I'm in the nonprofit space. I'm observing, right? I see kind of a struggle but by the public health sector and healthcare sectors together with what next steps they want to take on the ground, and feel the sense that maybe even they are becoming concerned because there's a lot of shifts happening. How do we keep the eye on health equity? How do we ensure that needed research on emerging communities like mine, the Latino community and other immigrant communities, and even migrations from state to state, and possibly the downplay of the roles that bilingual community health workers played this might be happening now. I get the sense that we're pulling away from some of the innovations that we had, but not just innovations, but also issues that we didn't emphasize previously that really made that shift and really got information on the ground to help our communities out. So yesterday, actually, I participated in a countywide meeting on Latino health in Prince George's. And it really, I started having these feelings back in November, and here we are in April, and it really hit me hard. And I feel we still may have some bumps in the road ahead. And that there are signs of shifts already taking place that may be less beneficial for vulnerable communities. So this morning, Andrea and I are going to take the opportunity to talk very broadly about some of the questions that lay before us, like the obvious: what do we do next? Where are the gaps in policy, services, and access to healthcare that are still present? How can we work together to make it better? And what are the essential needs, from my perspective, of the Latino community, but of vulnerable communities in Maryland system-wide? So let's get started, Andrea. I am so pleased to have you. I always like to begin our conversations with a little personal dialogue. I would love to get to know you a little bit better. Tell us a little bit about your work at Kaiser Permanente. I mean, your role as Senior Director of Community Health. Love the title. What do you love most about this work? How did you come to be part of this?
Okay, so I'm going to give a little history and then bring us up to speed. So I have spent over 30 years in community-based organizations. So my bread and butter has been being seated in community, working directly with community. I have worked in maternal health, early childhood learning, with the public schools, mental health services, health access, health services, health literacy, public housing, workforce development,
Oh, wow.
family court, and food security. So that 30 years, I've been around lots of blocks.
You represent social drivers of health. You are it.
Exactly. And so previous to coming to Kaiser, I was with Northern Virginia Family Service, which is a large nonprofit in Northern Virginia that served really the whole footprint of Northern Virginia, and ran a whole host of programs while I was there. Many of which encompassed families from really all over the globe, and worked in close partnership with people with all kinds of lived experience and identities. And so last year is when I was hired for the role of Senior Director of Community Health for Kaiser Permanente. And some of that was because of all of that experience that I've had, because Kaiser has a rich portfolio of work that they invest in. And there was a lot of experience, on the ground experience, not just that theoretical kind of experience, like, what does it really mean to do food for life? Like, I did the work kind of thing. And so for me, coming to Kaiser was an opportunity, and I try to be very blunt and direct. It feels different being on the philanthropy side than being on the community-based organization side. And so really being able to use some of my insights and experiences to kind of change how we look at how we do our charitable contributions. Some of those quiet parts that may not show up in the application, or some of those quiet parts that as community-based organizations, you're afraid to say because the funders hold the power. So for me, it was about leveling the power and sharing the power. And so what I really enjoyed in the last year of this role is really getting that really deep and rich understanding about how to use our charitable contributions in really meaningful ways. That we're not just looking at the outcomes of things, because folks like to look at, not outcomes, sorry, the outputs. Like, people like to do the count. And my question is, you can count it, but just because you count it doesn't mean it made a difference in anything. And so really embracing that outcomes-based learning, looking at ways to be innovative. Where are our incubators of ideas? So bringing all of that to the role as Senior Director, and being able to do it in a healthcare system where we know that the work that we do in community health has great influence on how things happen in that political setting. So I think that's my story, and I'm sticking to it.
I love it. I love it. I love what you said about focusing on outcomes. For me, that I write a lot of grants, and that's the fun part for me. Like, yeah, it allows me to dream. Like, really, if I had an ideal case scenario, what would the outcome be? And it makes me shoot for the stars, right? So I love that versus what I refer to as bean counting. I did X stories with X conferences with this many people, and this just showed up. But what happened? What happened? And it's actually one of my frustrations with writing federal grants, but I won't go into that right now. So let's switch gears a little bit, and I'd love to talk to you a little bit about the initiatives that Kaiser Permanente has embraced. I was really, like I said at the beginning, I was really impressed with that conference. I loved the concept of the intersectoral work, and I think what I came out of there with, it really, it made me feel how COVID-19 opened up all of our eyes to where the gaps between public health and public health care resided, right?
Yeah.
Your public health officials that were present were quite quite clear about some of the challenges that they've faced and some of the frustrations they have. But so are the healthcare providers. Like, it's not for lack of desire. It's just, how do we fix? How do we communicate? Literally, sometimes it's systemic, like literally systemic. Like the computer system doesn't communicate. So at the conference, Kaiser Permanente, I try to use full names, announced a three-pronged set of interventions to ensure that we don't forget the lessons from COVID. Maybe could you share with us some of what these are and why Kaiser Permanente and these amazing organizations and associations you brought together, why you believe that by addressing these intersections, we can get closer to broader public health and well-being?
So full transparency, because I think the only thing I know how to deliver is truth, and particularly my truth. And so I learned, Gabriella, with you at the conference as well. And so a lot of the work that happens in community health in our markets come from our headquarters, our program office. And so we don't always get all of the details about how that's going to actually land in the market. But what I will say is that it was really exciting to hear the thoughtfulness and the intention and really understanding, what this pandemic has unveiled. And that is that our public health and our healthcare delivery system can no longer work in silos, that there has to be collaboration and intentionality and how we share knowledge and tools and ongoing working relationships, so that we are always strongly positioned to be able to respond to the next thing, because there will be, the next thing. And the other thing was what really I think came to bear, and I was on the community-based organization side of that, is they can't do any of this work without community-based organizations.
Right.
We are, I'm going to use the we because I can't get rid of my past. We are really the cornerstone of community. We are the ones with trusted and valued relationships with the people who are really most vulnerable, who oftentimes need to be in receipt of the services that these kinds of public health emergencies, or just general public health concerns, impact communities. And so with that, it's really institutionalizing that understanding that community-based organizations play a critical role in ensuring that community voice is heard, and that those voices actually guide the public health response. It's also a way to identify and disseminate those best practices for making and maintaining those connections within community and between public health and the healthcare systems, and really improving the partnership so that people really receive the resources in the care that they need in times of really in times of in lean times and in good times, right? And so that was, the second thing. And then the third is there's this vacuum of knowledge and information that exists in our community, and it's understanding how do we make real investments in public health and research. We know that our public health system is woefully underfunded, and oftentimes some of the really essential and important work that they need to do, they don't have capacity to do, either in workforce or tools. And so it's how do you bring all of these stakeholders together to build up the body of evidence to understand how to make these impactful changes in our public health system and response in local communities and throughout the nation. So, we want to be prepared locally and nationally to respond to all of the things that would seek to threaten us as communities and nations. And so Kaiser Permanente is working with the CDC, American Medical Association, associations of health plans, the White House, Let's see, am I missing anybody, Gabriella?
It was quite a group. I mean, it was impressive. It's like everybody was at the table, and that was part of what was really impressive, because it was the finance piece, it was the data and research, it was the public health and the healthcare intersectionality, and then the issues themselves, and literally with just a laser focus on community. And you know, I mean, it's rare I come out of a conference with warm fuzzies, but I thought, okay, there's hope. Not only is there hope, they're willing to put their money where their mouth is. And that was exciting, because I want to be a part of that. You know, that's one of those things where I'm like, oh, count me in. Yeah, sure, I'll be there. But then I also realized, because in my presentation, I was like, ooh, resources. I want to be there, but I got to get resources. And so we had a really in-depth conversation about that, and the commitment to the nonprofit space I thought was really fascinating. And even the White House presentations that were made, there were 2 presentations, I believe, and they were very clear that has to be community centric. It has to be people centric, because that is ultimately, it's our health. It's each individual's health that comes to the table. So I feel like, you know, I'm all about next steps. So on that front, we have to think about social determinants of health, right? Because if 20% of health is healthcare, then 80% is social drivers of health. So what needs to happen then? I feel like you're the right person to ask to build kind of this health in all policies approach across our government agencies, our public health system, but also our programs as nonprofits, as businesses. Are there some obvious wins that we can go for collectively? And are kind of like, I always like to think process wise. So what are the low hanging fruit, obtainable targets, and then, you know, what can we do in the next couple of years just to get the ball really? I mean, I feel like the ball's already rolling, but how do we keep it rolling? Because I do fear, as I said at the beginning, that there might be some challenges ahead.
You know, one of the things that has been my experience is that people lose sight of the fact that this work is not a sprint, that it is a marathon, right?
Yeah.
And you know, as a Black woman, when George Floyd happened, you know, at the beginning of the pandemic, there were all of these folks that kind of, in a very performative way, jumped on the bandwagon that they were going to do all of this work, this racial equity work, right? And that they were going to hire these EDI officers in their organizations. And we're now about 3 years out, and a lot of that is starting to fade, right? And so just like that happens, I think when we think about the pandemic and some of the urgency and the need feels like it's fading, what we really have to be very thoughtful about is acknowledging, continuing to advocate, and really being committed, and bringing in all sectors. That this is not just when we think about social drivers of health, right? This is just not a public health or a healthcare system. I mean, it takes all of us being in the boat and rowing together, and it's really, you know, blowing that bullhorn to make sure that folks don't lose sight of that. I think really understanding these long-standing inequities and why the disparities exist in the first place is where we need to be reminded to stay centered. And then this willingness to change our systems structurally. And I think that involves, you know, really creating some legislation and policies that center health equity, so that we ensure that the most vulnerable, their needs are being met. I think it is helping our communities understand how to be politically involved and savvy so that the right candidates get lifted and elected. I think we don't recognize that there are a lot of opportunities for folks with lived experience to be on local boards, government boards, where they have an opportunity to lend voice and craft policy and how resources get allocated, for community, because so much of this is local. It's where you live, right? It's not your genetic code, it's your zip code. And that's where you need to be entrenched in and invested, right? And then I think the other part is, making sure and finding out what are the ways to make sure that our local government and community resources are appropriately invested when we center social and racial equity into those communities that have been long disenfranchised and disinvested in. And so it requires being active and engaged. And I know for a lot of our immigrant residents and refugee residents, that can feel scary. But I think that's where we as community-based organizations, we use our trust that we engender in those relationships to create those pathways to make sure that their voices get centered. And those that have more security step into the gap to be brave, to amplify those voices. And that's been how I've experienced and watched my fellow residents and colleagues navigate that space, so that that racial social equity and social justice becomes a reality for the many in the community. So I think when we think about, what are those things that, where are those places that we can move to, I think there's an ability for us we got to agree on the problem, right? Because if we don't agree on that, then the solution will not be focused and intentional, right? So it's agreeing on the problem, and really how do we co-design our solutions? And that co-design means bringing in all the applicable voices to be able to be a part of the solution, because we got to know how that problem is hitting on everybody, right? And then it's an opportunity for us to really understand how do we create and decide on what are the best practices that people and our organizations can agree to undertake so that we have that larger impact. And when we think about what are some targets, I'm gonna say I'm not sure.
That's where the conversation kicks in.
Yeah, I'm not sure. What I know is social, racial, and health equity would tell us that it's going to be different for every community. That's because right. The assets and the resources for each community is really different. So this is a Maryland conversation, but I'm a Fairfax County resident. And what I know is that in Fairfax County, we have our One Fairfax policy, which really embeds health in all of the policies. Mm-hmm. And so in how we look at and design solutions requires that we look at who is being left out, and then how do we design the response so that everybody is filtered in, which also means allocation of resources might be different because there's more disparity in the community. And so if we're trying to level and even that playing field, then the county has taken the position that we have to be comfortable that the ones that have may not continue to get, because we need to help the ones that don't have. And so I think each community has to really come together in a meaningful way to decide what is the problem and how do you solve for the solution, bringing those that are most impacted, those voices into the solution design.
That's a lot to unpack, Miss Andrea. So a couple of points really stood out in my head. Obviously, representation matters, right? So I love what you were saying about getting folks to participate in commissions and boards and make sure that officials who make decision makers get to hear the voices of the people, because if they don't hear it, they don't have to do anything about it, right? It means it's okay, right? In a way, it's like a quiet voice, no voice or quiet voice implies I agree with you. The other thing I heard is that your zip code shouldn't determine your lifespan, and that our solutions are really locally based. They used to, what is it they used to say in Washington? All politics is local. Well, in this case, all healthcare is local. You live where you live, and that impacts how healthy you are. But I also, this final piece about Fairfax, you're raising something in my head about models, finding best practices and models that actually function, and emulating them, if not emulating them, at least researching how that something similar might work here. And start local by local. We got a lot of work to do. Whew. And but that's exciting, because that opens doors for new thinking about how systems can interact. And then lastly, what really stands out is this idea of flexibility in the system itself, because each zip code is different. And this is going to be the tricky part, because it's a lot to wrap your arms around, and all these different organizations play a role. So how can we ensure that we're flexible enough that we can adapt, place by place? That's a lot.
I'll share with you, prior to my coming, Kaiser Permanente Community Health had invested in 3 place-based initiatives. And it is where they have looked at some data to look at poverty index, lack of opportunity, and other structural systemic barriers in a community that is really getting in the way of that community thriving. And so almost a decade ago, there was a community in Baltimore that they invested in. We are wrapping up the work in Greater Riverdale in Prince George's County. And we are working in the Colmore Bailey's community in Northern Virginia. And that has been one of the most challenges place-based initiatives to get off the ground. And so with Greater Riverdale Thrive, we now have a community established organization through this work that has stood up, that is the convening intersectional body that will institutionally keep that work going. And so there's some funding that we're doing to create the capacity of that organization to carry that work into the future so that it is not lost. But they have really brought in so many of the residents in the local community to understand, and there are different opinions about what the challenges are in the problems,
That's
right?
true.
Like some folks are like, we need more greenery, right? Neighborhood built environment and stuff. And then there are some folks that are like, no, we need food and we need job opportunities, right? But it's the community hashing out what it is that they have decided is and they've established a network and relationships to be able to advance that work, right? And that is and government has some involvement, but not much. But it's a community solution, right? And then our place-based initiative in Nova, what has been beautiful but yet challenging is that it is richly diverse. And so I'm gonna poke at something that might feel a little uncomfortable, and that is sometimes when you get these communities that are super diverse in lived experience and resources are low, you get competition in between the groups, right? So
That's true.
In this particular community, we have a large refugee population, but refugees from all over the world, right? And so each group has different needs. And when there's so much need, it's hard to agree on what the problem is.
Right.
So it's actually been a little bit of a challenge standing up because we're still trying to agree on what the problem is.
Right.
And I mean, that place-based work should take 5 to 7 years. The pandemic did not help. But it is a wonderful, it's a wonderful opportunity to dig into, to try to lift that community voice, to understand how do we partner with them to solve what they eventually decide is the greatest challenge to be able to solve for that community. But it's icky and it's messy, and I think sometimes we don't acknowledge that, but it doesn't mean that it's not worth the work.
Right. Right. No, and it's actually, it's what I call God's work. We've actually partnered with Greater Riverdale on a number of things as a result of it. And I know, Heather, you've been very involved in all of this. Heather Iliff, our CEO, she's been, a part of the Greater Riverdale Thrives process. Do you want to say a few words, Heather, about the experience? Or?
Well, I'll just say it's interesting, the framing that you give around, we're technically post-pandemic, but not post-health crisis. And I think in the Greater Riverdale community, that has been just really evident that, the system wasn't really set up to serve the residents very well in the first place. And now, during the pandemic, there was a mad dash to just try to get vaccines out. And, when someone has a whole lot of health needs, they might be facing, diabetes, they might be facing, heart disease, and receiving that diagnosis for the first time, or not even knowing where their symptoms are coming from. And, there's a public health imperative to get people vaccinated. Do we have as high of a public health imperative to make sure people's needs are met, right? So I think some of the things that are interesting about Greater Riverdale is how the community is physically placed in the town. You have a whole area of homeowners who are predominantly Black and with some other, white, Latino or Asian families and homeowners. And then you have a lot of apartments over here on the other side that are predominantly Latino and immigrant. And, just the nature of apartment living versus homeownership, you have just so much transience in communities coming and going. And so as we look at, the social determinants of health and the importance of being place-based, that knitting the fabric together with the two literally physical sides of the community has been one of the hallmarks of the Greater Riverdale Initiative, where you have Black and Latino co-chairs of Greater Riverdale Thrives. You have people actively coming together and solving problems together. In our state, I don't see a lot of Black Latino work being done, bridging those communities. And so I think as Greater Riverdale was just prioritizing health, education, food security, the basic needs, coming together around those basic needs and building community around them proved to be an effective focal point to bridge some of those gaps. So thank you to Kaiser Permanente for sponsoring that initiative.
Thank you, Heather. I appreciate hearing that. I'm still learning.
I guess I should say I'm remiss to not mention, and sorry, give me a platform and I'm just going to keep on talking.
Go for it, Heather.
Remiss to mention the core of that initiative included 5 to 6 local anchor nonprofit organizations, and the Greater Kenilworth Community Development Corporation, Sowing Seeds of Economic Empowerment and Development, also known as SEED, and Passion Community and Outreach, other local nonprofits, are really in the process of strengthening their long-term sustainability, their connections with community, their collaboration with each other, diversifying their boards to bring in that representation from the community they serve. So that has also been, I think, really impactful.
Thank you, Heather. I love the Greater Riverdale Project. I refer to it a lot in a lot of the work I do, and it's created some wonderful partnerships for Maryland Latinos Unidos to be able to work in the area. And we have now started to expand into environmental health. And for those people who want trees, we're with you. But I want to open it up to the group. Does anybody have a burning question that they would like to pose? Otherwise, I will keep going because you give me a platform and I talk as well. You know, my nickname is Gabby. But you know, if you want to just put it in the chat, go ahead, or raise your hand. Happy to hand it over. In the other thing, I think that comes out of all of this, and I think Heather, you're sort of referencing it, is this idea of primary care and the need for it. You know, you said that people getting the vaccine or finding out they had COVID realized they had other chronic conditions they didn't even know they had, right? So do you think, this is really an opinion question, so I'll just put that on the table. Yeah, I'm obviously pro. Would improving access to primary health care for the Latino and other vulnerable communities, do you think it would help to reduce inequities in health outcomes for this segment of the population that sort of on what we call the front lines, right? And, you know, obviously I believe that. But in practice, what I often find is that, especially in immigrant communities and even newly arrived communities, irrespective of where they come from, learning the system and how it's structured and how it works is complicated. So what kind, you know, they're met with barriers and obstacles, you know, whether it's legal status or insurance, lack of it, access to insurance, the ability to pay for insurance, not being able to access Medicaid for whatever reason, language, even a lot of language barriers. How can we encourage behavioral change to improve primary access in institutions?
Unfortunately, I have a lot of opinions about that because
I knew it. I knew it.
This is work that I was really centered in for probably the last 20 years. And two aspects. I ran a home-based early Head Start program for over a decade across several counties in Northern Virginia. And EPSDT or WellCare visits, as folks commonly know them, for the infant, toddler, you know, and youth population, helping some of our families who are newly arrived understand the why it's important to take a baby to the doctor at these regular intervals was a task. And then working with the adult population coming from other countries where the healthcare system was very different. Oftentimes it's a privilege to be able to go, or not understanding that there could be valuable in having an annual visit to understand how things are going and evolving with your own healthcare. Where we leaned in the most is really providing some health literacy, right? That was one of the ways to help people, if they had a plan, understand that plan, how to advocate for getting their needs met based on potentially their diagnosis or treatment options, understanding what it meant to actually have health insurance. So some of you might be aware in 2018, 2019, Virginia expanded adult Medicaid And so I want to be fair. It wasn't just, you know, folks, immigrants not understanding the American healthcare system. We had a whole bunch of folks in the state of Virginia and Northern Virginia who had never had healthcare, even as a child, who were embarking on healthcare the first time and had no idea what that meant. And so part of the work that we did was, as we were helping people to sign up for this new Medicaid product that they were going to get, we were also doing health literacy with them at the same time, helping them understand how to use health insurance, what that meant, what they have a right to, how do they advocate for themselves. Because you can lead them to the visit, right? You can get them the health insurance, but it doesn't mean that they're going to use it. Another example, Kaiser has a community health access program that maybe some of you are aware of. We call it CHWs. And basically, we have an open enrollment each year. We have some very specific partnerships across Maryland and Virginia. And basically, our non-documented or undocumented folks in the community have an opportunity to get access to a Kaiser ACA Gold plan for them and their families. And so we also have a kids program where our children who are undocumented or meet a certain threshold of income and are not eligible for Medicaid, they can also be enrolled in this program. The product is a little different, but what we were learning is, and I ran one of those programs, is that 2,500 kids would get access to this, getting any service that they needed within the four walls of Kaiser. And we've been learning that the parents are told that they're supposed to get this health access, but they only access it if the kids are sick, or they've had it for 2 or 3 years and they've never used it. And so there are some opportunities to do some health literacy around that. But aside from all of that, I also want to add that I don't know that our healthcare system is always inviting as well. And so let's call out a lot of the bias that we see when people are engaging with the healthcare system, and English is not their first language. And then, you know, it makes that clinical visit more difficult if translation is not a possibility. Sometimes those visits take longer. There's a frustration that happens that I think can impact the quality of that visit. I think we have a lot of folks who hold medical professionals in a certain esteem and aren't willing to question their treatment options. So I think all of this leads into the fact that being able to equip people with knowledge that is power and how it shows up in that primary care visit is important work for us to do in our community.
I love it. I so agree with you. I think we have a habit of looking at our insurance, you know, for emergencies. So like, okay, I have a crisis. I fell out of a tree. I broke my arm, says the little kid, you know, and or things like that. And that's how, you know, they're taught how to utilize it, as opposed to this idea that your insurance can help you get the primary care that you need, and so that you avoid worsening situations and don't have chronic conditions as you get older, whether it's for children or even if you're older, etc. We do have some questions from our audience, though. Vanessa, she has asked us, what are some of the ways to build the Black Latino bridge? It seems that we should understand each other, but there is a cultural divide despite living in many of the same communities. Any thoughts on that, regarding especially the experiences you just shared with us in Nova and Greater Riverdale?
Heather probably has way more information than I do about Greater Riverdale and the work that was done to bridge that divide.
Excuse me.
You know, for my experience, And the work that I've done, it's always, for me, just been about creating opportunities to bring any two different groups together, centered on something that is often important to both groups. So we've done a lot of convening when it centers around kids, because parents have very similar experiences. And sometimes you begin to build a relationship based on a shared success or a shared challenge. And what we've learned is that it takes time. It is not a quick thing, because the groups have to overcome any bias or prejudices that they may have of each other, or perceptions that they have of each other. And actually get connected to each other's humanity, is where I have found we've been able to be successful. But it's not quick work. It hasn't been quick work for me in the work that I've done. It's taken time to be able to build that trust
and confidence,
those relationships. Yeah.
That you can make the changes and that you can get to know each other. It's sort of like in kindergarten when you're little kids and you don't know each other and you're like, hi. I won't talk about kindergarten. So there's also a very interesting question from our audience related to current college students who are not health majors. How can we help educate them about such inequities and maybe find roles in community to bring their education to bear in fields? I love to start. I'm a big person on intersectionality. I love it. Like for me, everything's intersectional. I used to use the word interdependent, but I do feel that there's a lot of possibilities, and it's a great question. Like, I'm not from the health field, but I feel very passionately about it because it affects every other piece of my work. So how can we do something like that?
So I'm aware of a couple of things that are going on. Some of you might be aware that we have a health workforce crisis.
Yeah.
And some of you may be aware that addressing healthcare doesn't require everybody needs to be a healthcare professional. So when we lean in on community health workers, or community navigators, there are some coalitions that are getting together to be able to leverage their resources to create some local programming that give people an opportunity to do some listening and learning and understanding how they can become community champions and advocates related to social determinants of health and helping people navigate healthcare and healthcare systems. And so that's some work that I know that I'm doing in Northern Virginia with some coalitions as well. I think there are a lot of, many communities have local health departments that are required to do a community health improvement plan. And so there are opportunities, if it's acknowledged that health literacy is a challenge for that community, that could be the work that is undertaken within the CHIP, within the Community Health Improvement Plan. And so that oftentimes is reliant on public health, government, and community-based organizations and community residents coming together to set a strategy to tackle a particular problem that's been identified in a community, in a county or a city or whatever. So that's one of the ways to also bring folks together to solve for a problem, related to health literacy. Yeah.
I love it. It's actually, your answer is a nice segue for the next question, which is how do we fund health literacy? Because, I did notice this. There is a movement away from funding health literacy. We had a really big program in Prince George's, and the funding's just dried up. And we've been searching for new opportunities. And it's like, well, we're switching issues. We're moving in another direction. But health literacy is continuously changing too. What is health literacy? There's so many aspects to it. And it's, there's the system itself, there's the health literacy within the system. about community, and then there's the community health literacy about the system, right? And of course, both of us worried about what's happening in health, in new knowledge about what is health, right? And new things, science is math, it's always changing, right? So any thoughts on that?
I have a couple. One is, it is hard to get people to agree on what health literacy is, depending on your position and your perspective, right? You just said that very well. There's the health literacy and understanding an insurance plan, right? There's the health literacy based on my condition, right? There's health literacy and understanding in how do I navigate my environment so that I'm healthy. I mean, it shows up so many different ways. We are actually, and I believe in health literacy. So I believe, I'm just gonna be straight up. I think there'll always be dollars in Kaiser Permanente to support health literacy. Yes, you heard me say that out loud. When I was in Northern Virginia Family Service, we got funded a host of times by Kaiser Permanente to do health literacy. So, and during COVID, there were some dollars that came out around health literacy. So the need for it doesn't go away. Internally to Kaiser Permanente, there are some very specific pilots that we'll be doing around access to care and utilization. And so there's a concept that we want to prove internally within our system that I think then empowers us to be able to allocate additional funding to support health literacy. And that's going to require some connection and partnerships with community-based organizations. So certainly funding from health systems. All of the MCOs are, I think, really interested in making sure that people understand how to use their products and might offer some opportunities for that. But I would argue everything doesn't take money. And I'm speaking from experience. Sometimes there were things that I knew were important to do, and I found partners where we could blend our resources together to create a solution for the clients that we were serving. So maybe they did a little of this and we did a little of that, and we did an MOU and we partnered together for certain populations to be able to get things done because there was no money for it.
Right.
That's
I love that model.
On it.
Yeah, no, I love that model. That's one thing we learned during COVID. We created our MLU model, and literally we convene folks together. We talk about what it is we've got, what we need. We have this conversation, and then we cultivate the idea, right? And then we literally figure out how to collaborate and leverage those resources together. It's not perfect. I mean, I would rather see, let's put money on the table and everybody, be flush. But realistically, there's so much need. So there are creative ways, I think, to resolve problems beyond just that. I want to add, there's a comment in the chat that I like a lot. It says programs that help community members get linked to primary health care providers may prevent further health complications among community members. A stronger connection between PCP, primary healthcare providers, and underserved populations may contribute to significant savings for the health system as well.
So that pilot that I was talking about that we were doing, that we're doing internally, is really about understanding when you bring in Medicaid and Medicare members, our MCOs are required to do these touches with their Medicaid enrollees. And the question is, if you do a soft touch, which is the minimal thing, versus a more aggressive touch, what also creates an opportunity to provide health literacy, do you see better utilization in the system? That at the end, people are coming in earlier and discovering issues that they might have so that they get into treatment sooner, as opposed to ending up in that ER, having that cost, and then having an exacerbated medical condition.
Oh, that's good to know.
So there's some work that we're doing internally for that. I do want to go back to the primary care thing and behavior change just very quickly. And that is some of what we see and have experienced is that people get their primary care. And this is for folks who are uninsured and insured. They go to primary care and they don't get better for their condition. And so sometimes there's judgment on the patient about them not getting better, right? They're not eating well. They're not medicating their medication. They're not being compliant. And I think where we have to do better in our health systems is where we begin to really look at the social needs of our and our patients, and understanding that so we know that there are opportunities where folks are taking their insulin, they're taking it the right way, but they don't realize that maybe they're not housed, or they're living in a place where they don't have access to the refrigerator, and their insulin is not being refrigerated, so it's no good. Right? So behavior change is also behavior change on the part of the medical system, and understanding that there's an opportunity to address some social drivers of health that may be impacting people's ability to adhere to the treatment in order for them to be well. You told me to take this medication, but you didn't ask if I had a way of getting the medication.
Right.
Do I have access to the surgeon?
It really is about relationships, isn't it, and conversations. I mean, I think that really
and it's understanding that 20% is what happens in the visit, right? But that 80% is what happens when they come and go from that visit.
Right.
And how do health systems really start to address some of these things?
Right. Okay, we have one last question, but I think we've run out of time. I would like to hand it over to Veronica Kuhl, who is our chair and founder. Thank you, Andrea, from my part. Veronica.
Thank you so much. Andrea, you are just speaking truth to power. Thank you. And, a personal note of thanks to Kaiser Permanente for putting their money where their mouth is. We, as a Latino community, as a limited English proficiency community, as an immigrant community, we don't have access to the same resources. Everything is a little bit more convoluted, more painful, and we have an insane amount of advocates that are, toiling day in and day out with pretty much nothing. It's just their drive, because we're seeing our people dying, we're seeing our people not advancing, and we know COVID was a generational hit for us. We went backwards, mega backwards. So having a partner like Kaiser is phenomenal. My plea to everybody on the line is what Andrea said is true. We have to collaborate. The money isn't enough for every one of us to do our own little thing. As beautiful as the little thing is, I'm not demeaning it, it's just too small to be impactful or sustainable. So please show up, speak up, share your program, share your activities. And I'm going to ask Andrea and the other funders, the other big partners, let us know when you have opportunities to collaborate. Let us know when you have capacity building money, when you have dollars available, when there's a big grant coming and you need a doer. We have doers. We have tons of doers. So what we want is a little bit more partnership. So please, please, please keep thinking of us. Let's keep talking. Guys, if you're not a member of Maryland Latinos Unidos, please join in so you're in the loop. As we've said 100 million times, we don't want to do anyone's work. We want to do it together. You're doing beautiful work in your neck of the woods. We want to amplify it. If you have a brilliant concept in Montgomery County, we want to steal it with your permission, obviously, and implement it in Baltimore City, Frederick County. We have great need. We don't have time to start from zero. So the goal is to work together. So to close it out, just a shout out to Dr. Lemus for being so brilliant, for bringing in partners like Andrea, Kaiser Permanente. You guys, thank you for showing up, and all of you for giving us a little bit of your time in the morning to figure out how to do more and do it better. So un abrazote a todos. Lo aprecio mucho. Thank you, Gabriela.
Lost my mic. No problem. Thank you so much. Sadly, I could talk to you for hours, Andrea. I think you and I could have very long conversations that would lead to all kinds of really practical outcomes. But and thanks to the group here, everybody who attended. You guys have been amazing. Sorry, Maria, for not letting you ask your question. Next time.
Okay.
We're super excited to have you, and we're going to continue these conversations and dialogues. We appreciate you. Have a great weekend, and we will see you next month. Mwah. Un abrazo a
Thank
todos.
you. This has been a pleasure, and never feel limited in terms of reaching out. I'm always available to talk.
I'm going to call you.
Have a wonderful
Okay.
day.
Ciao,
Gracias
guys.
a todos.
Gracias,
Thank
gracias.
you.
Un abrazo.